Time to get started again, everyone. It is my pleasure to introduce our next speaker, Dr. Dawn Novak. She is one of our amazing attendings at UNM. I've known her a really long time, wonderful person. She attended the University of New Mexico, where she got her MD in 2008, completing her pediatric residency at UNM in 2012 and her fellowship in neonatology in 2015. During her fellowship, she worked on research related to maternal-infant bonding and its impact on developmental outcomes. She currently has a faculty appointment at UNM. I don't know if your introduction does you justice, Dawn. She's one of the loveliest people you could ever meet. She's so involved with our fellowship program. She's also our medical director, our interim right now. She's got a lot of irons in the fire, and we're so thankful that you could take the time today to join us and talk about your topic.
Thank you, Brenda. I really appreciate it. So this is one of my most favorite topics to talk about. It's the area near and dear to my heart. And one of the things Brenda didn't say is I actually started off with a plan to do child psychiatry. And people will sometimes joke that how did I end up in a profession? All you do is talk and taking care of patients who don't talk at all. But I actually think there's a huge overlap in neonatology and psychiatry, and my interest in brain and neurodevelopment has just continued through my career. It just shifted focus a little bit. And so I'm going to share my topic, and hopefully you'll come to love and see the importance of neurodevelopment and how we can help improve that in our preterm infant population. So the objectives today are to discuss the long-term neurodevelopmental impact of preterm birth, investigate the psychosocial effects of NICU admissions, explore how the NICU environment impacts families, and most importantly, because the first half of the talk is pretty depressing, to look at things we can do to improve outcomes, and then also look at some guidelines for when the patients leave our NICU and go out into the community, so how we can continue to support them outside of the NICU. So about 1 in 10 infants delivered annually will spend time in the NICU, and you think about that kind of staggering numbers. And there's a variety of reasons for that. And Dr. McKee just gave a lovely talk about some of our GI issues that we see in our patients. And we...
I'm sorry to interrupt you, Dawn. Do you have a way to share your screen?
Oh, I was just going to ask if you guys are not seeing my screen. So I thought I had shared it, but let me go back. I apologize about that. Can everyone see it now?
Perfect. Thank you.
Right. So like I said, Dr. McKee just gave a lovely talk about gastroschisis nymphalocele, and we do indeed see a lot of those at UNM, in addition to a variety of infants with genetic disorders. We have some babies down here who are undergoing cooling for hypoxic ischemic encephalopathy. But the patient population I'm going to focus on today is our preterm infant. I mean, truly all of these different types of infants could have their own talks because they all have their own kind of unique neurodevelopmental risk. But today we'll focus on our preterm population. And that is about half the patients we see in the NICU annually. So we do know that being born preterm is highly associated with neurodevelopmental outcome impairment. And so when you look at population studies, major disabilities exist for preterm infants in a range from anywhere between 20 to almost 50%. And really how big of a risk that is varies depending on how preterm you were born. So the more preterm you were, the worse risk you have for neurodevelopmental impairment. The unfortunate thing is these challenges or differences in outcomes can persist and often do persist, not just into childhood, in particular at school age, but even into adulthood. And we'll talk about that more in a minute. And that can be upwards of a quarter of our preterm population are being impacted into their adulthood years. So when we talk about neurodevelopmental impairment, what do we mean? So it is a variety of cognitive, neurologic, and sensory defects that we're talking about. So to begin with, cognitive is standardized cognitive tests, and there are a variety of those. It also could mean, in addition or independent of cognitive defects, motor defects, and then that we're referring to cerebral palsy, and we'll talk more about cerebral palsy in a moment. But that's really looking at a score of more than 2 on the gross motor function classification system. And so what is the gross motor classification system? That is a system that really looks at how independent you are on a motor level. And so here, you have your children who are able to run and go upstairs. They're going to be a level 1. If you have a little bit of tightness or problems with stiffness in your lower extremities, like dysplastic CP, you're going to be a level 2. If you're in a wheelchair or needing walkers, you're a level 3, and then level 4 and 5, you're more impaired. You have risk for hearing loss and also vision defects for your long-term neurodevelopmental outcome for your preterm babies. And really, the definition of legal blindness is more than 2 or 200 or less with your better seeing eye. And so when you're looking at these big studies, any baby who has that degree of vision loss and or needing amplification, they're going to be referred to as neurodevelopmentally impaired. So what is the risk? We do know that the risk increases with your decreasing gestational age. And so there's been these big international studies that have followed extremely preterm infants out for years and then looked to see how they do. So this is a really nice study. It was done in France about 20 years ago now it was started, but they finished collecting data just about 10 years ago. And so what they found is that the very preterm group, the group that was less than 20 weeks, had 5% of those patients had a severe disability, and then 9% were moderate and 25% were severe. 9% of those ended up with a CP diagnosis. And again, the risk increased for decreasing gestational age. But even in the patient population that wasn't considered CP or severe or moderate disability, there was still a significant chunk of these kids who were using specialized healthcare resources. And a lot of that was defined at needing additional help at school age. And that's a theme we see kind of throughout all of these studies. Another big study that was done here in the U.S., this is the ELGAN study, again, looked kind of longitudinally at infants born less than 28 weeks gestation. And they found similar things here in the U.S. So about a quarter of them had severe impaired cognitive abilities, 8% CP, so right around that 8 to 10% mark is kind of what you see consistently throughout studies, and that boys were at higher risk than girls. And we do see this kind of anecdotally in the NICU, that our little boys do tend to do worse than our females. And there's not a lot of data to explain why that is, but it is consistent kind of throughout these big longitudinal multi-site studies. And so really, I think this these bar graphs over here do a really visual, nice job to show how delayed this patient population is compared to the mean. So if you look at a kind of a mean patient population, if these children had a normal distribution for development, this is the 50% mark for all of these are the different types of neurodevelopmental testing that was done. And so in a normally distributed patient population, you should have the mean right around the 0 line. And then these are different gestational ages, with the youngest being the less than 24 weeks, which is here. They're all below the mean. You can see for all the different types of neurodevelopmental testing that's been done. So some kids, there are some outliers that do okay, but by and far, they're all below what would be expected for normal distribution on development. So one of the biggest things that preterm infants are at risk for is motor development. And we see this a lot in our special baby clinic, our NICU follow-up clinic. So these babies are at risk for delayed milestones. They often roll later than they should roll, crawl later than they should crawl. They have balance abnormalities, and then start having some problems with manual dexterity. And so some of this can be tested with coordination tests on the movement assessment battery test. And so coordination kind of is one of the problems we see over and over. And a study out of Norway showed that about 30% of infants later in life, so they were looking at these kids in their teenage to adulthood years, and 30% of them were still having problems with motor abnormalities. So again, we see these problems persist beyond infancy through the adulthood years. The good news is that we are seeing a slight decrease in our CP rates and the severity of CP. So a Neonatal Research Network study, the NRN, this is a consortium of different NICUs across the country that collects data, and then this data gets reported. So they looked at data for infants born less than 27 weeks and followed these kids out again. And then they did show that there was a decrease in CP from 16% down to the rates we're seeing now, which is closer again to that 10% mark. But more importantly, the severity of CP decreased from severe down, so increasing rates of mild, decreasing rates of severe. So seeing more mild CP, but less severe CP. Preterm infants are also risk for speech and language morbidity, and that's partly due iatrogenic causes of being in the NICU. So when babies are developing in utero, they're in a very protective sound environment. The inner ear, the cochlea, starts to or is completely developed by 25 weeks, so it's very prone to injury outside of the kind of protective uterine bubble. And so at 28 weeks, the hearing threshold in utero is 40 decibelmeters, which is the safe sound range for these infants. And just to give you a sense of the sound that these infants are hearing in the NICU, shutting and opening the isolette door creates a sound of 80 decibelmeters. And so that is twice, just opening and shutting the isolette, twice the safe level for these little babies. And that's morbidity that they're getting over and over throughout the day, or negative impact that they're having throughout the day as those isolette doors are open and shut. And so I'm constantly reminding our residents, if you can just slide the little isolette flick over and shut it quietly, you can help preserve some of their hearing or the impact to their hearing. But the environment that they're growing up in the NICU can lead to delays in their vocabulary development, phonologic processing, language comprehension, and then those then can start to affect cognitive, such as memory and grammar development. The good news is that survival without neurodevelopmental impairment is improving. We have made some progress even in these periviable infants. So it's not great. I will tell you, we sat and had a talk recently with the University of Iowa, who does a lot of these periviable infants. In fact, they have some of the best survival rates for periviable in the 22 to 24 week gestational range of anywhere in the country. But even for them, they were still seeing neurodevelopmental impairment in that patient population between 50 to 75%, but it is not 100. So we are getting better, and the data is supporting that. So even with this previable patient population, while they're at extreme risk for neurodevelopmental impairment, there are a growing cohort that are leaving the NICU without significant impairment. So this is kind of the bigger picture of long-term outcomes. But what does it look like for these infants once they go home and through the school age? So these infants that are preterm infants often are quite dysregulated. And what do I mean by that? So they're fussier. They're often harder to console. I really give huge kudos to the families who are taking them home because they're not easy infants to take care of often. They tend to have a lot of GI issues and trouble sleeping. They have problems with their sleep-wake cycles. Sometimes their sleep-wake cycles are reversed, so they're up at night and sleeping during the day. And the GI issues are really common. I see this all the time when we have these infants coming back in for follow-up into our special baby clinic, which is our NICU follow-up here at UNM. A lot of these babies are getting put on famotidine because of reflux. That could be a whole separate talk about why maybe that's not the best idea because there is increased morbidity and mortality that we've shown to associate with famotidine use. But I think people are desperate to try anything in these kids because the reflux and the GI issues are so prevalent. The other thing we see a lot is constipation. So just in general, kind of harder infants to take care of. And again, kind of that's been shown in these bigger national longitudinal studies about for infants less than 27 weeks, when you're looking at them 18 to 22 months, a third have behavioral problems and about a quarter difficulties with social emotional. And then at school age, they really start to often show some psychosocial and behavioral difficulties. It is very common in preterm infants to have ADHD type symptoms. A lot of regulation difficulties with poor peer interaction. They can be hyperactive, and they're often also really prone to anxiety and depression. And so it's really important to have good support in place for these kids, especially as they're transitioning into school age. And not surprisingly, they're more likely to be diagnosed with autism spectrum disorders and psychiatric problems. So executive function is a big concern for these patients once they're starting into school. They often have problems with their working memory, problem solving, planning, and organization. And so you can imagine these are all the things that are required to do sit and do independent work starting at school. So school performance often is negatively affected. The deficits sometimes can be subtle, so it's important for the pediatricians and the parents to think about getting testing. There is testing, full-age testing available through the state of New Mexico, so it's something really to think about advocating for with this patient population if there's any signs that there's struggle in school. And like I said, unfortunately, these problems often do persist into adulthood. And so, again, in studies following these patients into adult years, they preterm infants at adolescent age often don't make friend groups like their term cohorts would. They're often shy, when the good things is maybe they're less likely to engage in risky behavior unless they've got the ADHD diagnosis, and probably more likely to engage in risky behavior. And again, just difficult with the social interaction with peers. And then as young adults, they can have lower rates of educational achievement, which makes sense when you think about the executive function problems I just mentioned. which is going to affect employment and income, and then even the ability to live independently. And then taking all that together, they often do these preterm infants who have gone into adulthood sometimes report a lower quality of life related to these ongoing health issues. So, unfortunately, a lot of the diagnoses that patients can end up with in the NICU, some of the NICU complications can further potentiate these developmental problems. So, being preterm alone is a risk. And just if you get through the NICU kind of with an uncomplicated NICU course, that you're still at risk. But most of our patients, unfortunately, don't have an uncomplicated NICU course. Many of them often have additional diagnoses or problems during their NICU stay that then kind of are cumulative to their risk for neurodevelopmental impairment. And so things that we know are independent risk factors for poor outcomes are BPD, and some of that has to do with steroid use to help treat BPD. That's been shown to increase risk for CP. But then perinatal infection is really highly associated with worse neurocognitive outcome, and diagnoses like necrotizing encephalitis, sepsis, and certainly meningitis, ROP, and IVH all can be independent risks. But the biggest one, and I really want to harp on this because this is one of the areas we can actually target for improving our outcomes, is poor extrauterine growth. So postnatal growth over and over again has been shown, if growth is poor, to increase risk for impaired cognitive and motor performance. But again, this is an area that we can actually target for improving outcomes. So really, really important. And we'll talk about this kind of again at the end of my talk. Additionally, there are other demographic factors that are kind of additional risk factors. So there's maternal factors and then kind of infant factors. So the maternal factors are lower level of education, non-private insurance, non-white ethnicity, and being unmarried are all maternal factors that can lead to increased risk for poor outcomes. And then the infant factors, in addition to young gestational age or younger gestational age, low birth weight, smaller head circumference, male gender, which we've mentioned, multiple birth, and again, being non-white. And we're going to talk about some of these maternal factors here in a moment. This is one of my most favorite slides through this entire talk. And why I love it is because it shows the exponential growth in brain surface area and cerebral volume that happens during gestation. And so when you look at periviable brain, so right around in here, there is a lot that is happening, including structural formation that's finishing and then synaptic pruning that's beginning. But myelination really isn't happening until after 28 weeks gestation. So if you're born prior to that, you really don't even have the myelination process that a term brain is undergoing. And that is all happening here in the third trimester. And here's kind of a MRI image to show what a brain looks like around 26 to even 30 weeks. So you'll notice there's not a lot of pulsation in our gyri. The brain is very smooth as compared to the term brain. Then the cerebral surface area, starting from about 34 weeks to term, just has this exponential increase. And so it gets me to the point I want to talk about, which is our late preterm population. I've been talking a lot about our really at-risk infants, which tend to be kind of the 28 to 30 and below. And I think our late preterm population flies under the radar a lot of times, that 35, 36 week patient population. And again, anecdotally, these are some of the worst kids I see in clinic. And I think part of it, they fly under the radar and people forget how at risk they are. But also when you look at this picture, it really speaks to how much brain development is actually happening even in that late preterm population. And so it's really important for us not to forget our late pretermers, and that even though maybe they don't have the risk that the really preterm kids do, they're also often not getting the targeted intervention that extremely preterm group is getting either. And so I think sometimes they get forgotten about, and then their development suffers as a consequence. So just to remember, even in that late preterm group, a lot of brain growth is needs to happen between 36 and 40 weeks. But if they're born here, they kind of are still at high risk. And so another risk factor that we had talked about is IVH, and a quick look at what that is and why it matters. So intraventricular hemorrhage is something our kind of 30 and less populations at high risk for. And the reason for that is the germinal matrix is an area of kind of very fragile capillary development. It's not meant to be permanent. And so if you're born early, if you're born term rather, that area is involuted and gone away. But if you're preterm, the germinal matrix is still very vascularly active, and so very fragile capillary area, because it's not meant to be, like it's a permanent structure, and so prone to bleeding. And so you can have grade 1 through 4, obviously 4 being the worst. And so 1 is just a little hemorrhage. The 2, you have hemorrhage within the ventricles, but no dilatation. 3, you're starting to see some dilatation. And then 4, the bleeding's extended into the parenchyma. And then often this is when we end up seeing kids getting shunted. So certainly an extra added risk. And so when these kids are leaving the NICU, something to pay attention to, that if they've had even grade 1 or 2 bleed, which is, for us, we often kind of dismiss it, but again, significantly increased independent risk for neurodevelopmental outcomes. And so, again, this is just another area that shows ongoing changes that happen within the brain. So this is the brain of a baby who is born at 30 weeks and then is corrected to 40. So there's persistent high signal intensity in the cerebral white matter, just again showing persistent changes. And these changes, again, can be thinning of the corpus callosum, increased ventricular volume, and decreased gray matter. So that's a little bit about why the structure of the brain is at risk. But like I mentioned earlier, the NICU is not an ideal place to develop. There is a lot of noxious stimuli. We talked about the noise level being a risk. Light is also a risk. The intrauterine environment is a dark place. The NICU is bright, and while we do keep our isolettes covered, there's still light that's able to get in. Repetitive pain is another problem for these infants. We'll talk about that more in a minute. Often, there's exposure to analgesia, which is another risk for these babies. But then you also have the loss of normal stimuli, which would be parental touch, smell, voice, and breastfeeding, because these babies just neurodevelopmentally aren't able to start breastfeeding until about 34 weeks, which is when the normal suck, swallow, breathe brain regulation kicks in. And so pain or repetitive pain in the NICU is a problem. It's unfortunately unavoidable because we do need to do things, even which as minor as getting a heel stick that has been shown to, on a repetitive level, be associated with worse outcomes. So a recent study looked at how many painful procedures neonates go through within a day. They just counted up, things like blood pressure cuffs and heel sticks. And it was anywhere between 7 to 17 procedures in a day. The most frequent were heel sticks and suctioning and or IV insertion. And again, these are all things we're having to do to help keep the infant alive, but cumulatively does have an impact on development. And what happens with repetitive painful procedure is babies actually become hyper sensitive to pain, that lower pain thresholds develop. And some of this is because of increase in nerve growth factor or hyperinnervation leads to then to this hypersensitivity. Another thing that happens with chronic pain is this is a really interesting study that was done in rat pups. What happens is the HPA axis can actually become permanently changed when there is repetitive exposure to a noxious stimuli. So the HPA axis gets increased. It leads to increased corticosteroid levels, and then that leads to adverse brain development. And what it was shown in these rat pups that had over and over noxious stimuli, what happens is they were more anxious, had higher preference to alcohol, and then they started to exhibit withdrawal behavior. And here is a really nice picture of an infant exhibiting with some withdrawal behavior, with even something just as minimal as just listening to heart and lungs. And so you see the infant is turned away from the caregiver and then is giving the Palmer salute, which is the infant sign. And now the hand's not quite over the face, but this is the infant sign for I'm overstimulated, leave me alone. And certainly you see the infant with the palm up. The other thing that can happen with increased exposure to painful procedures is there can be some epigenetic changes or modifications that occur at the DNA level. And so, again, increased exposure to adverse events. There's DNA methylation that occurs, so epigenetic alterations in DNA, and then it leads to some downstream changes in behavior with altered white matter development. Again, the increased behavioral problems we talked about, and then decreased stress regulation. And in addition to the NICU being a difficult place for babies, it is very traumatic for parents and caregivers. When they do studies looking at stressful life events, parents who have had infants in the NICU report this kind of as high as they report other things like loss of a spouse or other very, very significant distressing life events. It often leads to some trauma that people continue to experience after the NICU. I've talked to many families in clinic who describe PTSD type symptoms related to their NICU experience. Often it's because of this grieving process that happens because you don't end up having the baby or the birthing experience that you were planning on. You really lose any type of control, especially if you have a very preterm infant, including even the ability to sometimes even hold your baby. What does that mean for a parent role? When you can't hold or comfort because your baby's too sick. In addition to that, just being in the NICU environment, the sights and the sounds and the noise can cause stress. So even if your baby's doing okay, the one sitting next to you might not be. And all of that kind of leads to this ongoing trauma for families. Not surprisingly, postpartum depression is very high amongst moms who have given birth to preterm infants. It can be upwards of 40%. It is a little less in fathers. We'll circle around to that in a minute. Maybe talk about some reasons why that is. So looking moms of healthy term infants, 6 to 12%, like I said, 30 to 40% of the moms who gave birth to preterm babies. And if the baby is sicker, that those risks are higher, not surprisingly. But other things that are, I feel, particularly pertinent to our patient population in New Mexico are things like distance to the hospital and ability to visit. Many of our families are not from Albuquerque. Sometimes they're able to relocate and be with their baby while they're in the NICU. Oftentimes, if there's other kids or job obligations, they're not able to do that. And so that kind of contributes then to the postpartum depression that these moms and dads experience. And unfortunately, prenatal depression and stress actually can contribute to a preterm birth. And so then you're setting up this cycle that you were not doing well prenatally. You have a preterm birth, which then increases stress and postpartum depression. And then it creates this unfortunate cycle that we sometimes can see with then impact actually on the baby. And we're going to talk about why that is. And some of that is because of the just inadequate ability that moms who are severely depressed and with high anxiety, they just have decreased ability to care for their infants. And as I mentioned, fathers have less stress in the NICU. There are less rates of depression than moms. And some of that is because the NICU is a really unique place for fathers. It's uniquely challenging for them. And so it's even harder for fathers sometimes in the NICU to bond with their babies. You think about one of the opportunities that mothers have is when babies are starting to breastfeed and going skin to skin. And dads have a limited ability to do that compared to moms. And this was a really interesting study that was done in Denmark. And what they did is they wanted to create a father-friendly NICU. And so they really brought dads in. They had them engaged in child care activities with things like diaper changes and feeding the baby. And the goal was to be supportive and have dads have a good NICU experience. But what happened was at the time of intervention or at the time of discharge, the overall stress scores for the intervention group were higher than the control. So the dads who were supposed to be in the supportive NICU environment had higher stress levels at time of discharge. And I think that what that speaks to is that they were in the NICU more. They were exposed to those stressors more of the NICU environment, including the lights and sounds that we talked about. And so their stress was actually higher. So how to support fathers in the NICU or male caregivers in the NICU kind of remains a challenge and something to kind of be extra cognizant of. Family structure really does have a big impact on future performance for preterm children. And so this is one of the areas where we really can target some intervention. So when, and this is kind of gets back to the research I did as a fellow and some projects I've been involved with ongoing, that infants who were born preterm into families where it was a married dyad or a stable dyad, they did better in school and needed less special education as compared to infants who were born into homes with single moms. And so the family structure really does can either uniquely be protective or an additional risk for a patient population. So, as I mentioned, our preterm infants tend to be fussier. They tend to have be just more difficult babies to engage with. And because of that, it can be harder for them to bond with their mothers. And so there's been several studies done on still face, and what that is moms and babies interacting together. And what it has shown is that babies who are in the NICU or ex-preterm babies are often more difficult to arouse. They are less socially interactive, and then they give mixed cues of wanting attention, but also being distressed. And so what can happen is one of two things is in the mom's trying to engage with the baby, she can become very intrusive and controlling, or the moms can just kind of become less responsive and response to the baby being less responsive. And really either of those are suboptimal for that dyad and then the ongoing development in the baby. But we do know that the mom's ability to engage in a healthy way can be protective, but it can be challenging because just of the nature of the social limitations of ex-NICU babies. And so what can happen then is, like I said, there's risk for attachment impairment. Parents of infants who are born preterm have been shown then at times to become controlling, intrusive, and overprotective. And so you think kind of the helicopter parents, and it's a bit in response to the fragile child syndrome. So you've had an infant who's been sick. They haven't had the normal bonding experience. And then again, this overbearing parenting can then lead to downstream emotional problems for the infant. So again, it's kind of creating this unfortunate negative cycle. And as with other negative consequences of prematurity, it doesn't just end in infancy. The challenges to bonding can persist into childhood. This was a Finnish study that looked at maternal-child bonding in preterm boys and preterm girls. And interestingly, they found that the moms with preterm girls, when they went back and asked them about their childhood experiences, and this was when they were adults, they described their mothers as being overprotective and somewhat authoritarian. Now, they didn't see that quite as much for the boys. The boys, it was more consistent with the term controls, but certainly even through adulthood, we're looking back thinking that the bonding was affected with their mothers. So again, this just really speaks to an area that we can help provide some intervention and hopefully provide some support for the babies. So we do know that if we can improve the parent-child relationship and provide better synchrony with that dyad, that can be tremendously helpful in long-term neurocognitive outcomes. And so the better the home environment, the more supportive the home environment, the better the base for a baby to kind of explore the world, and then the better outcome they're likely to have. And so really, again, supporting these families, not just within the NICU, and trying to help with that bonding to as best we can in the NICU, but encouraging that once we leave the NICU can be very protective. So again, this is just more research that has really supported that mothers who were born to preterm or who had children that were born preterm, the dyad partnership is extremely important. And so moms who were supportive and gave good scaffolding to their babies, and again, that's allowing them to kind of explore the world in an emotionally supportive way. Those babies went on to have less behavioral problems and tended to do better with things like social communication. So the dyad relationship, again, just is very important. And this has been shown even just with things such as play. So if, again, moms can give kind of these babies who, like I said, are at risk for some behavioral problems, ADHD type things, and executive functioning, if the moms are most of the literature has been done with moms, but the little bit of literature that's been done with dads have shown the same thing. But if they can provide some external structure for these kids, giving verbal direction, helping sustain their attention, they are able to accomplish tasks, and that then can go on to provide the baby ability to have better working memory and spatial processing as they age. So all of these things kind of speak to how important it is that we provide comprehensive family-based care in the NICU. What does that mean? So that really means it is super important to try to engage families on rounds, that we work with families as partners, that we include them in medical decision-making, unrestricted visiting hours is important as much as possible. And also studies have shown having the ability to bring other children in the NICU can be very helpful for families. Now, this is completely gone out the window with COVID, but prior to COVID, we did let children over the age of 14 come in. Unfortunately, with COVID, we've really limited this, but hopefully, as restrictions ease in the future, we'll be able to help support families in this as well. If we can get families to read to babies in the NICU, that alone can be very supportive. One of our fellows is working on a very exciting study right now, looking at maternal voice exposure and effects on EEG changes. And we're really hoping to show that reading to a baby, we can have some positive EEG changes. But we do know in some of these longitudinal studies that babies that are read to have significantly better language scores at 18 months. So vocalizations, as much as possible, has been shown to be important. And we are working on ways to have maternal or exposure to voice more often, including through tape recorders in the NICU. Neurodevelopmental care is very important. Here at UNM, we're really lucky. We're the only NICU in the state that has early intervention services that start in the NICU. So we have occupational therapists and behavioral specialists who work with our babies and our nurses and our families to really promote positioning strategies, gentle touch, where we're constantly trying to modulate the light and sound exposure, like I've talked about, and really trying to bring in parent involvement as much as possible. And this is just ongoing evidence that shows, again, that these things really can help. So the best level of evidence is kind of over here with these big arrows. So again, if we can decrease painful experience, help protect sleep, reduce exposure to narcotics, and improve skin to skin, all of these things can go on to help our babies once they leave the NICU. Breastfeeding is definitely been shown to be protective and can increase IQ scores later on. And that's due to a variety of reasons. But in particular, I think it has to do with that bonding that goes on in improving the dyadic relationship. And so lots of studies have shown that there's better cognitive outcomes for infants who are breastfed as compared to formula. So the more we can help encourage breastfeeding for as long as possible, the moms pump in the beginning. It's really hard when you have a baby who's not going to be able to go to the breast for weeks to months, but encouraging moms to pump and then really supporting breastfeeding once babies that do develop that suck, swallow, breathe can give our preterm infants advantage. And transition to care is super important. This is an area I'm really interested in, and we're working on some projects here at UNM to help improve our transition out of the NICU into home. But it has been shown that if there is good transition to care, that families actually may have reduced rates of PTSD. Certainly, if you're preparing them, they're going to feel less anxious. So good planning, good support systems in place, early teaching is all very important. We're working really hard here at UNM to ensure all our families who've been in the NICU over a month are going home with any type of specialized equipment or getting a discharge care conference where the entire point of the conversation of how to transition back into the home environment or into the community. It's very important that babies who are in the NICU, born preterm, have ongoing neurodevelopmental evaluation. So for us, we do see our babies back at our NICU follow-up clinic, our special baby clinic, and we are screening them and really trying to get families enrolled in early intervention to continue once they leave the NICU. But when you're assessing babies for development, it's really important that you remember that they have to be corrected for prematurity until 2. So they need to be looked at by their expected due date, not by their birth date. It's not fair to look at a 28-weeker who's 2 months old and compare them to a baby born term who's 2 months old because they spent a good chunk of that time just trying to get to term.
I'm so sorry to interrupt, but we're over time.
Okie doke, that's perfect. Thank you so much.
We'll be sure and post your slides.
Yes, I was just almost done anyway, so it's a perfect time to end.
And we'll include the questions if you wouldn't mind answering those by email. Thank you so much for your time and your expertise. That was a very informative presentation. Thank you.